Really, the main goal of implementing outcome measures is to improve care for patients and families, and to enable you to demonstrate the high quality of care that you do provide. But I'm now going to talk a little bit more about why we're saying that it's such a good idea, and also about some of the other opportunities that lie within measuring outcomes on a regular basis. So the evidence to date, several studies have been conducted in the past that looked at the effects that outcome measures have on processes and outcomes of care, and Fliss touched earlier on these three concepts of structure, process and outcome. And we at the Cicely Saunders Institute have recently completed a systematic review that hopefully will be published soon in the Journal of Pain and Symptom Management that looked specifically at what happens when outcome data is collected and then fed back to health professionals, and how that impacts outcomes of care and processes of care. And I'm just going to give you a glimpse of the results of that review, and they're not out yet, so you're being privileged here. So the review looked at processes of care and outcomes of care, and I will talk about each of those in turn. So there were several studies that looked at the effects of outcome measurement on processes of care, and they all seemed to find an overall beneficial effect, or the majority of them did. So it appears that having outcomes data available does allow for a more complete or comprehensive picture of the symptoms that a patient is experiencing, but also that a palliative care population, so the population using your service, for example, is experiencing. Having outcomes data available also appears to facilitate communication about health-related quality of life between patients and health professionals, and it can also lead to a shared understanding of what quality of life ratings mean. And finally, studies also showed that healthcare outcomes data enables professionals to take action. So if you've got an outcomes data score in front of you and it indicates some kind of problem, it enables you to then say, okay, I'm going to change the medication of this patient. However, obviously your experience plays quite a lot into that as well. So the evidence for beneficial effects on processes of care, such as communication or symptom identification, is quite positive, and we know that measuring outcomes routinely has a great effect on that. The review also looked at what happens to outcomes, so what patient experience. And I have to say that the evidence for this is a little bit less convincing. So some studies looked at whether outcomes in terms of overall health-related quality of life of the patient is affected if outcomes data is available. And there didn't seem to be any evidence from those studies that there's a beneficial effect on overall health-related quality of life. Now, that doesn't mean that there's a negative effect on health-related quality of life. It just means there's not necessarily a significant positive effect on overall health-related quality of life. Some studies also looked at overall symptom burden, and they also didn't seem to detect an effect on overall symptom burden that was beneficial. However, again, that doesn't mean that the symptom burden gets worse if outcome measures are used. It just means that there doesn't seem to be any evidence at the moment out there. But some studies looked very specifically at subsets of patient outcomes. And those studies that focused on emotional well-being, looking at how the patient was doing emotionally, did manage to show a positive effect. So if outcomes data was available, then the patients appeared to benefit emotionally. And it was the same for studies that looked at caregiver distress. So a study found that caregivers experienced less distress when outcome measures were used and the teams were using the outcomes data. So just to summarize, again, what this review really tells us, and what it doesn't tell us, I suppose. So if you have a patient with an unaddressed need and you collect an outcome measure for them and you've got the outcomes data available, then that data, together with your clinical experience and with discussions that you might have had with your patient, can enable you to have a common understanding of the patient's symptoms and a more complete understanding. It enables early identification of symptoms, maybe symptoms that the patient might not have talked about themselves. So it might not necessarily be pain, but we might be talking about things like anxiety and distress that are a little bit harder to just see by looking at a patient, and that they might not share as readily. And there's also evidence that outcome measures lead to greater awareness of what's really bothering the patient. Now, as I said, outcomes data also leads to better communication, discussions of health-related quality of life. And all of this can enable professionals to react and act based upon their experience and those outcome scores to then, for example, change the medication or refer the patient on to another service, such as a social worker. And further down the line, that benefits the patients, and it appears that it benefits their emotional and psychological well-being. But as I mentioned, the evidence to date doesn't indicate that there seems to be a benefit for physical symptoms or overall health-related quality of life. Now, that review is just hot off the press, basically, but it doesn't answer all the questions that we might have. So, for example, although the review shows that there is evidence that there's beneficial effects, particularly on processes of care, we don't really know what's going on, and we don't really know how those effects come about. And although we have this good evidence about processes of care, we don't really seem to have that much evidence about outcomes and how having outcome measures and outcomes data available affects outcomes. And finally, when we looked at the papers that were included in the review, we found that most of them were from an oncology outpatient setting. And now I think we all know that oncology is really only half the story, because a lot of the patients in a palliative care service have a non-cancer diagnosis. So we are not convinced that the results from this review can easily be applied to a non-cancer population. Similarly, outpatients tend to be the patients who are slightly more well, let's say, and who are more independent. And maybe that means that we can't just simply say these results are also true for inpatients. So there's work to be done here with under-researched populations, because most studies happen in oncology outpatients. So within OACC, we have embedded 2 research strands that try to address a little bit of the gaps that I've just told you about. So one of them is a qualitative work strand, which will involve interviews and observations with stakeholders, including patients, caregivers, and health professionals. And that will explore, hopefully, how outcome measures work or how they don't work. So it'll look a little bit in depth at what happens when outcome measures are used. And the second work strand will be a feasibility study that will explore whether a large-scale trial on implementing outcome measures will be possible in the future to address some of that low-quality evidence that I've just talked about. So as you might be able to guess from that last point, in the future we hope to do a larger trial about effectiveness of outcome measures to really look at what happens when outcome measures are implemented and when they're used to processes of care, and particularly to outcomes of care, because we need more evidence in that area. And as I mentioned as well, it is worth thinking about further studies that particularly look at under-researched populations, and those might include the ones with a non-cancer diagnosis, they might include inpatients, and they might also include people who don't speak English, because sometimes if you put a PROM, a patient-reported outcome measure, in front of them, they might not be able to complete it. And they might need help, or it might work differently for them. So that's something else that we might need to look at. So there's a lot of opportunity alongside the implementation of outcomes to do some evaluation work and to do some research in collaboration with research institutions like King's, but also yourselves, the healthcare institutions, and other organizations such as Help the Hospices, who we're already working closely with. So we're hoping when you're implementing outcome measures, you might think a little bit about what you might do in terms of evaluation and research. And I think we have a panel session now, so thank you.